About management of mild and moderate TBI. So, Lenin, if you're ready, shall we start?
Yes, ma'am. We can start now. So today's case presentation on neurotrauma patient. This is a patient name is Mrs. XYZ, a 32-year female, came with a history of road traffic accident. Date and time of injury is on 21/12, 2025, 3:30 p.m. She was a two-wheeler pillion rider, and the two-wheeler hit against four-wheeler. Initially evaluated outside hospital and take a CT scan and referred for neurosurgical care. So in our hospital, we received the EMR and immediately patient put on trauma survey. Primary survey, the patient was assessed with airway and C-spine protection. The patient's airway is patent. Patient is speaking well. And clinically, cervical spine clinically it was stable. CT cervical spine also done. It was having and CT spine injury was excluded with CT cervical spine. Coming to breathing respiratory rate is 20 to 24 per minute, and SpO2 was 98 on room air itself. And chest exhalation, chest auscultation shows bilateral air entry equal. On circulation, patient pulse was 102 per minute, BP was 110 by 60, peripheral perfusion was adequate, and there is no obvious external bleeding noted. And neurology disability, neurology GCS was eye opening to call, just verbalizing, and M6 response with the GCS of 13 by 15. On examination of pupils are bilateral 2 mm equal and reacting to light. There was no focal neurological deficit found in the EMR. Last and primary survey exposure, there is my tiny abrasion noted in the right forearm, 10 cross 5 centimeter, and outside that right temporal suture wound was noted. So coming to secondary survey, patient with RTA with head injury, there is gave history of loss of consciousness and vomiting present. There is no history of any seizures noted. There is no ENT bleed, and there is no focal deficit or limb weakness present. Past and personal history was uh, there is no comorbid. Patient has no comorbids, and there is no drug allergy. And LFP was 8/12/2025. Coming to 6A, systemic examination, CVS is next to normal, and RS there is bilateral air entry, equal air entry, abdomen soft and non-tender, spine no tenderness, long bones, no deformity noted. And EFAS done in the EMR itself is negative. A neurological examination, patient was conscious but drowsy. She was oriented but mildly irritable. Patient was mildly irritable. And motor functions, moving all four limbs. There's no sensory deficit noted. The cranial examination, which was grossly intact. There is no signs of any ICP, raised ICP. Coming to patient was shifted to as patient was having um, head injury and loss of consciousness with vomiting. Patient was shifted to CT. In CT, brain shows the CT brain, right side temporal EDH with a small SDH noted.
Lenin, let's take let's stop here for a while.
Yes, ma'am.
So, summarize the history and findings at this point.
This point, a young lady presented with history of traumatic brain injury, road traffic accident, traumatic brain injury. And since her GCS, initial GCS was 13 by 15, she has and also associated with vomiting and initial LOC. Patient was taken to mild traumatic brain injury. And since there was loss of consciousness and vomiting, the patient was taken for CT. CT shows on EDH in the right temporal region, which does not cause any mass effect.
What was your GCS?
13 by 15 ma'am. E3, V4, M6.
What is the ATLS definition of mild head injury?
Mild head injury is mm, uh, in respect to the GCS, it is 13 by 15 is mild head injury, and 9 to 12 is moderate head injury, and
That
anything
is
less
the
than 8.
classical. That is the classical division.
Yes, ma'am.
ATLS division is only 14 and 15 mild. 13 is taken as moderate. So 13 is a gray zone. Nobody
Yes,
is sure whether we should take it as mild because once you say mild,
yes,
the
ma'am.
whole prognostication becomes much different.
Yes,
And for insurance sake and other things in the Western world, the extent of investigation gets reduced. Whether you need to admit the patient or at the OPD, at the ED level, you can discharge the patient is another question. Is
yes,
there
ma'am.
any recent advances which will help you to decide whether you should do imaging for such a patient, mild head injury? Say, instead of 13, she was 15, not even 14, she's 15. She could be 15 with CT findings. Don't you agree?
Yes, ma'am. Yes,
So, suppose she was 15. Is there anything which will help you decide whether you should image her? Point
yes, ma'am.
one. Second, whether she requires admission. What is the
Yes,
recent findings?
ma'am. The patients, I mean, this is Canadian classification. No, the patient GCS is GCS dropped to 2 in the next 3 years, or there is seizure, or there is any new focal neurological deficits, or patient was on any anticoagulant. At that point, we need to
So, how long will you keep in the ED before you admit?
Shalini, can
is
I add here?
need.
In the history, when the patient can comes, is the event of amnesia important?
Yes,
Nice.
ma'am. Yes, ma'am. If amnesia persists, if it is more than 30 minutes, we need to go for a CT, even though the patient GCS is 15 by 15. And we need to keep in observation for more than 8 hours, please 8 hours.
Other than Lenin, anyone wants to answer any recent advances which help you decide, especially for mild moderate head injury, uh, about admission, about imaging, about prognostication?
Uh, Vomiting.
You're on the wrong path. It's not clinical.
Okay.
What is recently being said so much about TBI? Where is the money going for research? Serum biomarkers. So,
Okay.
Lenin, are you aware of any of the serum biomarkers that will help you?
No, ma'am.
S100B, GFAP, not heard of them?
I've read, ma'am, but
You need to read,
heard.
you need to make notes because in no time it will be available in India also. As of now, they have not come into guidelines. There's a lot of promise in these being used they're not so much of a good prognostic marker, but they are excellent in telling you whether you should go for imaging for one imaging for a patient, especially in conditions like sports people. They
Yes,
have a concussion. So, like what Sushma asked, unconscious for 15 minutes, get up. Are you ready to go back and play? Do you have to do imaging? How long do you wait? These questions are answered by these serum biomarkers. Another thing is group of diffuse axonal injury. These guys, to begin with, may have a good score. CT scan will be almost normal. You have to go for advanced imaging. The decision to move from CT to MRI, for whom and when. Again, in that scenario, these biomarkers are of help. So please do read about them. Okay, it's much coming up very quickly, so it will be for us to face these very soon. So update. Please go ahead.
Okay. This is the CT imaging patient. This initial CT findings were right temporal, frontotemporal acute extraction hemorrhage in the form of right temporal epidural hematoma, right frontal lobe thin SH, the punctate hemorrhage contusions present, right parietal bone fracture, and right temporal bone fractures. There was no obvious midline shift noted, and the ventricles were normal, and basal systems are pattern. Notes there is no much of cerebral edema. This was the initial CT cervical spine, no fracture and subluxation. Initial lab values were normal except leukocytosis, polymorphic leukocytosis, it is 19,000. Platelet were normal. Conclusion, the final diagnosis is traumatic brain injury with mild to moderate TBI, presenting with right temporal epidural hematoma um, with intact GCS. Management was started from here, and there is no indication for neurosurgery for this patient with this ADH. The patient was
One more
taken.
break, Lennon.
Yes,
So
ma'am.
obviously you had already admitted this patient at this point, right?
Yes.
First round of talking with the relatives. What is the update you will give? Why did you admit? What are you expecting?
Uh, since the patient has more mild GCS drop and vomiting, his CT scan shows some extraction hemorrhage. I'll tell
Why?
the patient that the patient had mild to moderate head injury. There is propensity to uh,
Hold on. How many hours since the injury is it?
uh, this injury. It is
Now,
8 hours, ma'am. 8 hours.
do you expect what is your CT finding? There is an EDH predominantly.
EDH.
What is the usual time frame it is going to expand? Usually 6 hours. If there is no hematological
Yes,
derangement,
up
you've
to
already
48
done your lab
hours.
work. You've already done your lab work, and there is no bleeding diathesis. You do not have any penetrating injuries.
Yes.
So very unlikely this is going to have a chance of expanding beyond the usual coagulation profile. Okay. So what is the time frame you will tell them in which time she's likely to deteriorate? So what will your admission time period be?
Today we say, this risk of expansion of hemorrhage in 48 hours.
Okay.
So she needs close observation and hence she need to be admitted
Okay.
for monitoring of GCS and other signs.
Dr. Shalini here to add is once again, you said rightly sent to us. Just 1 minute. The moment we try to taper anti-edema measures, especially with mannitol, the edema can increase on fourth and fifth day also. Huh? So in the
Yes.
beginning, what matlab you are telling rightly that it can increase, but when the moment we start tapering them, many a times you can see the increase in edema.
True.
Is that myocarditis re-expansion edema or a clinic pathology itself?
Usually, when you take off the anti-edema measure, there could be a rebound.
Okay.
So that's one. You also have a subdural on the other hand. What about that?
It was very thin subdural hematoma, that frontal area, with the small contusion, punctate contusions.
Those punctate contusions could bloom in the next 48 hours. So, to
Okay.
be on the safer side, whe- when you are explaining to the family, it is nice to say the major problem is unlikely to worse. We'll keep on in observation. But there are some other pathologies which might require a re-imaging. And if she doesn't wake up, we'll take up another CT scan, and there are chances that these small things may have gone up, or we may see some new ones. Like if there is a diffuse axonal injury which was not picked up with the acute changes, and later on it comes up. So it is safer to tell there might be something coming up in 48 hours, and we'll be watching for that. What is the criteria for evacuation of an EDH? This EDH doesn't warrant a neurosurgical intervention, you already said. So when does an EDH warrant an intervention?
The EDH was volume is more than 30 ml.
Mhm.
And,
So I'll give you an instance where the volume is 50 mm, but and the patient has come within an hour of the injury, RTA, and within the collection you have hypodense areas. Will you not operate? Will you not rush to theater? You will wait. What will you do?
needs to be shifted to ICU, sorry, to the theater, ma'am, because there is hypotenuse lesion showing that ongoing bleed, acute bleed.
What is it called?
It's, let's see now. See.
Swirl sign.
So, it's saying that is because of the an arterial bleed, middle meningeal artery.
Yeah.
So there's high possibility of expansion of the EDH and causing infection.
You're right about the volume, but volume is not something written in stone. Depends upon other radiological treatments which show that it might be ongoing and it can, because it is arterial, in no time it will swell up.
Yes.
That's the. Please go
Sure.
ahead.
So, in view of stable GCS and the EDH volume, the patient was put on conservative and management with a close neurological observation. And we'll check for the Harley serial GCS with and vitals monitoring.
Dr. Shalini, did we ask? I joined late. Did we ask about the lucid interval and which is
We did,
worst,
we did.
SDH? Okay, sorry,
Please go
sorry.
ahead.
Okay.
Please go ahead, ask.
Yes, ma'am.
Then we will
Sush-
not repeat the same questions.
No, I haven't asked Sushma. You go ahead and ask.
Okay. Dr. Lenin,
Yes, ma'am.
so patient with EDH comes to you, and as we have decided the admission criteria, he's conscious, obeying, and they have it is medical legally, isn't it? It is
Yes, yes,
RTA.
ma'am.
And he goes home because he's conscious obeying in small nursing, and later on then lands with unconsciousness. Why it occurs so?
This is called user interval, which initial shear forces causing a brief loss of consciousness. And
Uh-huh.
once the EDH, since the artery, once the EDH increases, it causes
Why does the ADH increase?
it is an extradural, ma'am. It's because of arterial bleed. It
Or which
tends to
arterial?
middle meningeal artery.
Correct. Good, good,
Mostly
good.
bridging arteries, middle meningeal artery, because of the arterial bleed, it tends to expand, and once it expands and compress the brain, patient goes into again a brief period of mean, again goes into loss of consciousness.
Again, to add over here, many a times in the bone, if there is fracture, ETH is there, many a time there is a fracture. These are emissary veins, and the vessels in the bone do not contract. Okay.
Okay.
So there are high chances it increases. Okay.
Okay.
Okay. Go ahead. Go ahead.
So patient put on medical management. Uh, Injection levetiracetam 500 mg IV BD was given. Injection pantoprazole 40 mg POD. Injection MZ 4 mg TED. Injection paracetamol 1 gram. 6th hourly given. So during the hospital course, she was admitted in the neuro ICU and monitored clinically. ENT opinion taken for the temporal bone fractures and to, I mean, to rule out any CSF leak in the CSF otoria. There was no neurological deterioration found. Follow-up CT after 72 hours was shows there was no new bleed. On the EDH itself, there is altered densities. It shows the blood is forming clot formation occurs. And patient remained stable and improved symptomatically. On
One
day
second,
7,
one second. So, two questions here.
yes,
Why did you start levetiracetam?
um, of all cases, patient with a traumatic brain injury with ICH, there is
This is extra
indication
detail.
for early to prevent the post-traumatic seizures. To prevent early post-traumatic seizures, need to go for either phenytoin or levetiracetam.
Exactly. For parenchymal. This is extra detail.
There is a
Okay.
small
Now, once you
contusion.
have started anticonvulsant, although it is not indicated, what should I do?
And
Continue how
continue,
long?
we can continue for 7 days, ma'am.
Correct, correct, correct,
And then
correct.
we need to
Huh?
stop that from there.
Yes, yes, yes. In between, you said some Canadian classification. Okay.
Yes, ma'am.
Should I ask you one more question? Now, this patient has presented to you, and you have decided that admission karna hai. So,
Yes,
what
ma'am.
trauma workup when it is indicated? First question. Second question is my what do you mean by ski bora if I do cervical spine and all everything? So just two questions be asked for trauma cases.
Regarding Canadian classification, uh, if since the since she have mild traumatic brain injury
Yes.
and there is any drop in GCS, this is say 8 hours. She needs admission, observation admission, and the
Let me
CT
just to
shows
add over here is when should I do a spinal workup because this is traumatic brain. I totally agree. But when patient comes to us, whenever there is patient is unconscious, first thing. Second thing, there are local. If patient has good localizing sign, definitely is conscious, moving. I'll exclude the spinal injury. But in patient who is accompanied or there is a history, his colleague has been who dies on spot. So this gives us indication that it is a severe
high
traumatic head
velocity.
injury.
Yes.
Yes. So then
The
it
high
is
velocity
alarming to
injuries.
us. Yes. Good. We have to, it is alarming to us, isn't it?
Yes,
And
ma'am.
suppose you are managing the airway and I shout in between that there is some hypotension. What will you do? Will you leave your airway and come and help me?
No, ma'am. Actually, for that we need to stabilize his spine
So
before we
first
proceed.
you have to answer airway always stands high. No
Yes, ma'am.
matter what, first I'll tackle the airway
Yes,
and
ma'am.
then we will concentrate on the
Commodity needs.
okay. Yes,
So,
yes. Okay. Certain mnemonics like sample history you should know.
yes, ma'am.
They can ask and localizing signs. These things definitely you should know. and you should know here the pupils you uttered. So here in application of your pupillometer, second thing, if you cannot monitor the pupils, what will you do? Because it has been monitored, isn't
Yes,
it?
ma'am. Yes, ma'am.
Yes, yes. So you have ultrasound also to help you out. Okay. Okay. Go
Drawings.
ahead, go ahead. And ONSD, you need to keep in mind. Huh?
Yes, yes, ma'am.
Okay.
One more thing, Lennon. Why did you
Yes, ma'am.
seek ENT opinion?
Since there is a temporal bone fracture,
Where is
uh,
the temporal bone fracture? Which part of the temporal bone?
must temporal
It's the squamous temporal bone which is
thumbs.
fractured. When is it likely to have any ENT consequence? When it is the petrous part. You may have a CSF otorrhea, or more likely, you may have some facial involvement. So, whenever you have the blood coming through the ear, you may
Because
also suspect that there is a petrous fracture and there could be a CSF otorrhea. How will you differentiate whether it is simply a blood from the ear or is it mixed with CSF? What is the simple bedside test?
it's teardrop test, ma'am. The drop test. If we if we place that drop in a gas, it
Mhm.
shows some target sign,
Correct.
central
Very
bleed.
simple. And if it is really there, what are the consequences? What are the next things you should take care of if there is a target sign
There's
on the account? Come
there's
again?
chance of meningitis, ma'am. Next
Yeah.
post-traumatic meningitis.
Yes, is very high. So any fever he subsequently develops, you should keep meningitis way up in your differentials. Thank
Yes.
you. Please carry on.
Patient remained stable and improved symptomatically. On day 7, patient's vitals were stable and GCS was full E4, V5, M6, and pupils equal and reactive. And patient was ambulatory without any deficits. So patient was discharged with this was written the discharge summary. Patient left resting with 10 days. The Vertin was 16 mg for 10 days and PAN and tablet with for 5 days. So patient was advised to keep in regular follow-up. And this outside temporal sutures, 3 sutures were present, was removed, advised to remove outside and to take head injury precautions.
So what are the overkill in your medications?
Sorry, ma'am.
What are the overkill in your medications? You've gone way up
Yeah,
more than what you
levetiracetam
were
and
doing. And
levetiracetam and
yes,
this Vertin also.
yes, and all three medications are not needed. Why are you
Yes,
giving pantoprazole?
there's no need, ma'am.
Patient is eating, no? 15 by 15 patient
Yes,
is eating.
on day
What is the
7.
harm of giving pantoprazole?
It causes say, not tubular injury. It causes AKM, the prolonged thing.
Also, the GI pH will be changed. That's not a very good thing to do, no?
Yes, absorption will be hampered, calcium absorption.
Yeah. What is these head injury precautions?
It's
You've written in your advice head injury precautions. What are
yes,
the precautions you tell?
not to have any forceful head movement.
Mm-hmm. What else? So I'll give you a hypothetical situation. This patient was someone with a right temporal contusion, and you're sending them home with phenytoin, and he's picked up to 15 by 15. In that instance, you have conservatively managed, you've not operated. What are the head injury precautions you will give to such a patient? Anybody can answer. It's not must that Lenin should only answer.
Phenytoin is indicated not to skip the drug.
Come again, phenytoin is?
The phenytoin is indicated
Hmm.
not to skip the drug.
Okay, okay. What else? In
Temporal
their
control.
day-to-day function, what all precautions should they take? Along the lines of the risk of seizures, what other things?
They should have enough sleep.
Correct. If they are driver,
Try to
uh,
avoid
uh,
in the night drive.
Sachi
Avoid.
says avoidance of tight neckties. Okay. If they have any work which is involved with height, they should, like electrician or a construction
Risk of
worker,
fall should be
risk
avoided.
of fall. If they are drivers, they shouldn't take it up. They
Okay.
may have seizures. Then, if they are already known case of seizure on other drugs with phenytoin, there is a lot of metabolic issues. Many drugs will have their serum
Seizure
value reduced.
increasing.
Yeah, so they have to keep a, they should meet the
Okay.
doctor and tell them.
Yes.
And with respect to the location or and nature of the head injury, I said contusion in the temporal lobe. What else could happen? Hyponatremia is a very big risk, and the edema can swell up even later on after 7 days, 8 days. How long will you keep the patient in the hospital? You will eventually discharge at 5 to 7 days.
Yes.
But the risk of swelling is still there. So Sanchi says serum, sodium monitoring, and magnesium. Good. So serum monitoring has to be done. Rather than the monitoring part, you tell them to add extra salt in the diet. That comes with
Yes.
the question, suppose he is a cardiac patient. He would have
And
been already told from the cardiologist that he should reduce or have no salt diet. In that instance, what will you tell them? Normal salt diet. You can't ask them to take high salt diet, at least normal
normal.
salt. And if a patient is not on any no cardiac risks, you can ask them to have a high salt diet. What would your target sodium be? Why are you asking them high salt?
Target sodium is normal 140 to 145
Yes.
milligram.
And when will you ask them to follow up back with you?
And 2 weeks.
Yeah, so in that intermittent period, they should have at least one serum sodium checked.
Okay.
What other precautions might be needed? Sanchi already said sutures, if not already taken off, should be kept clean. So many of the people have this fear that you shouldn't take a head bath. That's a myth. If the suture is taken off, you can go ahead and have a head bath. Normal life, normal mobility, normal activity, normal diet with some extra salt, and no losing sleep.
Yes.
There is no extra precaution you have to take. Carry on.
Dr. Shalini, have we asked him about the factors which will contribute at the see primary injury is the one which will decide about the severity of injury to the brain, correct? The mode of injury. Now, what are the events during transport? So that is trimodal distribution of mortality in the head injury. First is the mechanism of injury, whether which is with which it occurs. So if it is severe, definitely we have to discuss with the relatives and tell them this is severe. But what events in the hospital or during the transport are going to increase the secondary head injury? Lenin?
This is secondary brain injury causes.
Yes. Yeah, what
So
will cause
secondary
the
brain injury
damage?
mainly it is due to excitatory neurotransmitter released at the time of the brain insult.
Dr. Lenin, I'm asking which episodes will increase your or cause increase in the secondary injury. So there are
Hy-
very few things. First is a
Hypoxia, hypotension,
yes, correct. Hypoxia, hypotension,
hypotension,
yes,
hypothermia,
then yes, hy-
hypoglycemia,
yes,
and
temperature, yes, hypotension, yes,
hypercarbia, hypercarbia also causes
yes, and acidosis,
acidosis.
acidosis, yes. Huh? Okay,
Yes,
okay.
Once again, Lenin, there's a
yes,
question. When to start 3% saline or mannitol, basically anti-edema measures in EDH? You want to answer?
yes. I want to clear also actually. For EDH, mannitol is advised if there is any diffuse cerebral edema. But in other ways, the brain shrinks with the anti-edema measures. The EDH lost its um, tamponade effect and it will increase. This, I need to be clear with them.
You're right. So there are two schools of thought about this. One is that if the brain shrinks, the EDH will swell. That is a problem when you are not acutely intervening on the EDH. So these are not the life-threatening EDHs. Okay. And there is an underlying parenchymal injury. So you have to weigh the risk versus benefit. The parenchymal injury is going to likely to get enlarged, and at any cost you want it to shrink, you can go ahead and do. Like we discussed earlier, the EDH has its own lifespan where it is going to expand. It's not going to expand throughout.
Beyond that,
So
okay.
if that risk is low, you go ahead and start. Okay. On the other hand, EDH is one pathology which increases so fast that antiedema is not going to take care. So, like we discussed, if the volume is more than 30 ml and there are hypodensities within the collection, antiedema is not the answer. You can't waste time with antiedema, you have
Oh,
to surgically evacuate. So, the antiedema for an EDH alone, almost no role. EDH concomitant with parenchymal damage,
yeah.
whichever is more prominent, that will decide whether we should give or not. And there is one more. In case of drivers, risk of toxicity, urine toxicology to rule out alcohol and amphetamine, cannabis, and other viral markers. Okay. Okay, continue.
So actually, the prognosis is good with the mild TBI with a low risk of long-term disability. And as you told me, counsel regarding post-concussion symptoms like headache, uh, possibilities of seizures, and drowsiness, and slow in motor activity for few days should be reassured.
One second. So, one of the most practical problems all of us will face or have already faced, they will ask for leave. You have to grant them leave. And for many of them, this will be a good excuse to work from home. How long are you justified to give them leave? With a simple EDH, nothing else.
But it's on the work also, and 4 to 6 weeks. No?
With EDH, 4 to 6 weeks you will give. Productivity of the whole nation will come down when all EDH is sitting at home.
Not face. It depends on the work also on the patient. As you told, if the patient is a driver, need to be
Yes, so
more
you
time.
already said the need. First of all, there is not much need for anti-epileptics, and if at all it
Okay.
is there, it is only 1 week. So
Okay.
definitely by a week they should be able to go for work. You don't need a prolonged
Okay.
rehab and things like that, which should keep them tied down to unemployment. They can go back to work. There is no harm. Okay, carry on.
So presentation on this discussion. For the discussion, this case is 30-year female with RTA related to TBI. mild to moderate TBI because of the CG, according to GCS. And CT shows EDH with a small contusion in the left frontal with thin SAH and skull fractures. She was hemodynamically stable, and she represents the complicated mild TBA or moderate TBA spectrum, and she requires hospitalization and monitoring managed conservatively with a good outcome. So this is pathophysiological correlation. This primary injury is EDH, that is arterial bleed minimal jet. This is a kind of a discussion part. Contusions are coup and counter coup injury. You should add HH also as a primary injury. Secondary injury, the preventable or hypoxia, hypotension, rise recipient Jesus, which has not occurred in our patient. This management aimed at preventing the secondary bleeding of the TBA occurs. This is though Brain Trauma Foundation guidelines for the severe TBI. These things can be taken up for a mild to moderate TBI also to maintain this systolic blood pressure of 100 to 120, 110 to 100 to 110. In this part, um, to 15 to 49 years, it is 110, and for 50 to 69 is 100 systolic BP, and more than 70 years, it is 110.
So, are you going to stick to this for a hypertensive patient also?
No.
What are you going to do? In real time, you have all the non-invasive ICP monitoring gadgets in hand. What are your targets? How will you help? Which one will you choose, and how will it help you to reach your target? Before that, just 1 second, there is one question there asking that if there is a severe injury and the serum sodium targets and osmolality are reached, then till how much time do we have to give the antiedema measure? So usually we give it for 48 hours and then start coming down, because the chance of injured blood-brain barrier letting the heavy molecules like the 3% saline mannitol to cross over into the injured brain is also true. So that can again cause the injury to swell up even more. So beyond 48 hours to continue is not all the time productive. So we start coming down. Okay. And that is the scenario where all the experiments about steroids was tried. Dexamethasone in various dosages was tried. It went up to third level. And then when it was in animal study, it showed very much promise. But then when it was tried in human trials, it didn't succeed. It was so disappointing. But with that, those disappointing results of steroids, we do not have anything beyond anti-edema measures right now. Future, let's see if something happens. Yeah, you continue.
And that's what I was actually going to speak in between and tell that when we are going to give mannitol, what we should monitor is the osmolality. So that is the one thing we need to monitor. And as Dr. Chalni said, it can cross the blood-brain barrier. Here, so 3% question can be asked. We are using 3%. So with 3%, we'll monitor serum sodium. And with mannitol, we are going to monitor the serum also.
Yes,
Lenin, continue
yes,
with your discussion.
yes, ma'am. The oxygenation should be maintained more than 94% of SpO2, and avoiding prophylactic hyperventilation helps in sudden rise in the ACP. Avoid prophylactic hyperventilation prevents the ischemic areas, penumbra areas. IC monitoring, it's not mandatory in stable or mild to moderate TBA, which is indicated in the severe TBA. And antiepileptic prophylaxis, as discussed, it is for 7 days.
Yes, so I had asked you basically what would your target be? Will the SBP targets be individualized for a patient, or these numbers is what you'll follow?
It is individualized, ma'am. Actually, for hypertensive patient,
So, what physiology are you trying to attain?
It's auto-regulation, ma'am, actually. This auto-regulation for hypertensive patients, the MAP levels will be higher, bit higher for hypertensive patients. For them, we should not uh, reduce reduce the BP much to avoid
That will be
ischemic.
smart answer for any question related to any level of severity of TBI. If you are asked what is the futuristic management, it is always individualized.
Okay.
And most of the physiology is geared towards maintaining the cerebral autoregulation. Okay.
Yes,
So, obviously, in mild to moderate head injury, you're not going to put invasive ICP. So,
yes, ma'am.
how are you going to get any crude idea about what's happening to cerebral autoregulation?
Sorry, ma'am.
Without the invasive ICP,
Yes, ma'am.
how are you going to get a bedside idea of cerebral autoregulation?
It's targeting the map, ma'am. On indirectly tells about the cerebral perfusion pressure.
Okay. So, what gadget will you use to monitor?
There is the pupillometry and uh, Doppler
How is
TCD.
pupillometry going to help you with cerebral autoregulation?
Tells once the edema increases. TCD,
What?
ma'am.
Yes. TCD is the only thing that can help you with respect to the flows
Yes,
of all the non-invasive gadgets. Which values will you use?
resistant index will be higher in this patient.
What is more popular, resistive index or PI?
Resistant index in TBI patients.
PI is more used. Pulsatility index is more commonly used. And the rough, this is the rough cutoff is around 1.2. And so you can do an estimated ICP, plus you can go by the PI, plus the waveform also. Doppler
Yes,
waveform will also give you an idea of what is the width of your waveform. That gives you an idea of what is the compliance of the brain. So, more or less, a crude idea of what the cerebral autoregulation is obtained by the various factors of the TCT. Sushma, you want to add something to that, please?
Yes, yes. Similar to the waveforms which we see even in the invasive ICP, similarly waveforms can be seen. I think there is one image and I don't have right now, but you can go and find out in the Brain Trauma Foundation. Definitely the waveform on the ultrasound. So ultrasound waveforms will get changed as per the change in ICP. Number one. Number two, one should remember that the as PI is also important, but the mean arterial pressure plus the you should always see that diastolic pressure should not fall down. Your diastolic pressure, because brain is the very hungry organ. It requires hypermetabolic. If you see that there is a continuous flow, even diastolic flow is seen in the waveform. You see the TCD that there is, it never touches the baseline. It is not zero, never zero, isn't it?
yes,
So that you have to remember in the diagrammatic representation. Even if you keep that image in your mind, it will help you. Okay?
okay.
So, if say the systolic touches the baseline, what is the
Uh-huh.
condition?
Lenin, huh?
Systolic, systolic beeping.
Yeah, in the TCD waveform, Sushma said in TCD waveform, the systolic waveform never touches back to the baseline. There is always a perfusion. That is what is quantified as the diastolic. So in a situation where the systolic waveform has touched the baseline back in a patient with severe TBI, you've done a TCD, and this is the waveform you see.
Critical,
That tells you what?
critical IC intracranial pressure and intracranial hypertension. There's no flow, the
Yeah,
loss of
yeah.
flow, ma'am. From the
Technically, it is cerebrocirculatory arrest.
yes, ma'am.
Brain death is a clinical term. Equivalent term on ultrasound is cerebrocirculatory arrest. So basically, like she said, brain is a hungry organ. It needs, and especially when injured, the flow demand is much more. So it should have a very robust diastolic flow. And when ICP is so high and it is squished off all the vessels and there is no diastole, brain is dead. Okay.
Any blood entering.
Yeah. Sushma, anything else we need to discuss?
Looking for I have one snapshot. I'll send you. Maybe because of the network, I'm not able to share, but I'll send you few things about the waveform which I had taken one photograph on one of the call. You can share with the children. Huh? I'll just send you.
Sure.
Okay.
Sure, sure. Anybody else has any questions? Lenin, are your slides done?
Yes, ma'am. Already discussed things with
Continue,
nice,
please. Continue.
nice and injury guidelines. Pertinent to this case, indication for CT scan in this patient is GCS less than 15 at 2 hours, history of LOC, vomiting, and signs of skull fracture. And the other indications were immediate CT within 1 hour of request. That is GCS of less than 30 when assured in the emergency department. And GCS drop of, less than 15, 2 hours after the emergency department assessment. Suspect open or depressed fracture, which is present in this patient's signs of basal skull fractures, which we see that battering sign. If the seizure is persisting and a focal neurologic deficit present, or more than one episode of vomiting, and if the patient is on anticoagulant therapy, there is a need for CT head imaging in adults with mild to moderate head injury, mild head injury. Repeat CT is required when the pre-traumatic amnesia is more than 30 minutes and the age is more than 65 years. If any amnesia or loss of consciousness since the injury. And ma'am told that the dangerous mechanism, high velocity injuries, any amnesia or loss of consciousness, it's injury. Or fall from height of more than 1 meter or 5 stairs. For this patient, abnormal CT scan and skull fracture and intracranial bleeding are the requirement for the admission. Management, this EDH surgical need or not. As ma'am told that the size of EDH is more than 30 ml, regardless of the GCS. The midline shift is more than 5 mm and clot thickness of more than 15 mm. And if there is GCS, further GCS drop, nuance of GCS drop or focal deficit or anisocoria, the patient needs a surgical evacuation of the EDH. This antiplatelet reports. Yes. That's it. This
The
slide.
criteria changes in the posterior fossa, you know that, no?
Yes, ma'am.
Yeah. So beware when you have the same
Yeah.
volume in the
Same volume
anterior
we
cranial
can.
fossa versus posterior cranial fossa.
Yes,
That
the
becomes the
modal
life-threatening.
supratentorial.
Anybody has any questions? There's nothing in the chat box. We've answered everything. If not, we'll wind up. Lennon, wonderful. Once again, you started the new year with a bang. Do you have any more presentation before your exams? I don't think so.
This is the last one.
Best of luck, both Hari
Thank you.
and you. We'll
Thank you.
see you for exams. Sushma, thank you very
Thank you,
much.
ma'am.
You took the discussion to another level.
Thank you.
I'll
Thank you.
share
Thank you.
the images she sends to me. Thank you very much.
Yes.
Everybody,
Yes. Good.
thank you for joining. We'll meet in one fortnight time. Thank you. Bye. Good night.
Thank you.
Thank you.